Good evening, everyone. I'll be speaking on panuveitis. The International Uveitis Study Group has described the definition of panuveitis as a generalized inflammation of all three parts of the uvea, the iris, ciliary body, and the choroid. So the evidence for the choroidal inflammation can be any of these things: choroiditis, retinochoroiditis, or necrotizing retinitis. And it also includes vitritis and anterior uveitis. There can be many panuveitic entities, and like any uveitis, the diagnosis is based on a careful history, examination, and tailored investigations. Let us look at one of the most common entities of panuveitis which comes to our clinic, the VKH disease. It is a severe bilateral granulomatous panuveitis with extraocular manifestations involving the central nervous system, auditory system, and the integumentary system. It is a T lymphocyte-mediated autoimmune process against the choroidal melanocytes. The trigger is believed to be a cutaneous injury or a viral infection which causes sensitization to the melanocytic antigens. The exact target antigen is not known, but it is believed to be a tyrosinase-related protein or a 75 kDa protein or the S100 protein. It is usually seen in the 20 to 50 years age group, women and Asians being more commonly affected. If the patient comes to you in the early stages of the disease, they usually come with complaints of headache, and the ocular features you see are an exudative retinal detachment. It may be either a focal, multifocal, or a bullous RD. And depending upon the severity of the disease, they may have optic disc hyperemia and edema. Usually the disease is bilateral, but at the time of presentation, it may be asymmetric. If the patient presents several weeks or months later with poorly controlled disease, then they may have features of ocular hypopigmentation in the form of a sunset glow fundus. You can see the RP defects here and the complications like subretinal gliosis and pigment migrations and complications of cataract and glaucoma. They may also have features of cutaneous hypopigmentation like vitiligo and poliosis and alopecia. Now, since VKH is a choroidal disease, ICG is a very important method of investigation. You can see the hypofluorescent dark dots of ICG showing the choroidal granulomas much better than the FFA. Now, the FFA is also useful to pick out the pinpoint leaks in the early stages with the late pooling of the dye in the form of lobules. And you can see the hypofluorescent rim of these lobules, which are suggestive of the septae between the lobules. ICG also shows the fuzzy choroidal vessels and the late hyperfluorescence of the inflamed choroid. CSR is one of the very important differential diagnoses of VKH disease, especially if it comes in the early stages. And you can see in the OCT here how clear the vitreous is in the CSR with a smooth RPE, whereas you can see the RP undulations, the choroidal thickening, and the elongation of the outer nuclear layer in the VKH, and the vitreous cells which are there in VKH with the turbid subretinal fluid and the what we call the bacillary layer detachment here. The multimodal imaging in VKH is also very useful, not only in the diagnosis but also in the follow-up of the disease. You can see the hyperfluorescent, the hyperautofluorescence in the active disease, which normalizes after treatment. And the hypofluorescent dark dots on ICG co-localize very well with the flovoid areas on OCTA. And the SSOCT is also very important in picking up the septate subretinal fluids and the choroidal thickness, which dramatically improves with treatment. Some of the rare complications are neovascularization of the disc, which we saw in this patient of VKH, and some CNVM. Now, a large number of patients can undergo remission and cure before depigmentation occurs if there is early initiation of therapy. Given that the window period is about 2 to 3 weeks following the disease onset, if you treat them with a combination of steroids and non-steroidal immunosuppressives. But remember that as the disease resolves, there can be subclinical choroiditis, which you can monitor with ICG if possible. Because if you miss this window period, then the patients can go into a chronic VKH, which is not prone to remission and can have ocular and extraocular complications. Sympathetic ophthalmia is a very important disease which resembles VKH very much, but the most important difference is that it occurs after penetrating injury. A very significant landmark paper was presented in the year 2000 by Kilmartin and co-authors. There was a population-based study, and at that time the prevalence rate was around 0.3 per 100,000 per year, but now the incidence has reduced considerably. This also has similar features like weak age with vitritis, exudative retinal detachment, but the systemic features appear to be less common. The FFA sometimes shows the starry sky appearance, and hot disk means that it's an inflamed eye. This is a rare case of sympathetic ophthalmia presenting signs of frosted branch gingivitis, which was published by Dr. Biswas. The best way to manage sympathetic ophthalmia is a prompt wound closure and a good wound closure. Enucleation of the injured blind eye within 2 weeks can help in reducing the incidence. But once the disease process is apparent, enucleation is controversial. In the present day scenario, the incidence of sympathetic ophthalmia from penetrating injury is decreasing, but there is a debate whether it is increasing following vitreoretinal surgery or whether the antecedent trauma is making the difference or not. The study from Kilmartin also confirmed that a good visual prognosis is related to prompt and adequate systemic immunosuppression. And one of the more recent studies by Dr. Partho Majumdar on pediatric sympathetic ophthalmia also showed that the visual outcome even in children is very good, with which them achieving 612 or better vision in 70% of the sympathizing eye. Behçet's disease is common amongst the Japanese patients, who show more than 58% of the Japanese patients have complete Behçet's with HLA-B51 positivity. What is important to remember is that the uveitis in Behçet's disease follows the onset of oral and genital ulcers by a few years. They present with bilateral iridocyclitis with or without hypopia and vitritis, but they also have obliterative retinal vasculitis, which rapidly progresses to optic atrophy. This was a rare case of atypical Behçet's disease, which we saw. As you can see here, the patient had a completely quiet eye and there was nothing in the fundus, with just a macular hole. But somewhere in the periphery, he had a small segment of vasculitis, vascular sheathing, which prompted us to do the FFA, and then we saw extensive capillary leaks, and the patient also happened to have HLA-B51 positivity and oral and genital ulcers. And as you can see, this is not pathognomonic, but very often seen in Behçet's disease, this Perning pattern. Sarcoid disease is uncommon amongst the Asian Indians, but presence of panuveitis is seen in about 6 to 33 patients of sarcoidosis, and the presence of panuveitis is considered as a poor prognostic factor in these patients. The International Workshop on Ocular Sarcoidosis defined certain criteria for it: the mutton fat keratic precipitates, the vitreous snowballs, the peripheral multifocal choroiditis, the disc nodules and granuloma, the nodular and segmental periphlebitis, and the candle wax drippings. And they also included the negative tuberculin test, the elevated serum ACE levels, the chest X-ray, and the abnormal CT scan. But the diagnostic test in all of these is if you can demonstrate a non-caseating granuloma from a tissue biopsy, like the skin biopsy. So a biopsy proven with a compatible uveitis is needed for a definitive ocular sarcoidosis diagnosis. Sometimes OCTA can pick up these small phlovoid areas of the granuloma, which resolve well with treatment. Tuberculous uveitis has already been spoken elegantly by Dr. Biswas. I'd just like to say that the tuberculous uveitis is a secondary disease and may be either direct mycobacterium infection or a hypersensitivity reaction. And a large study on ocular tuberculosis from India showed that panuveitis is about 11% in all cases of ocular tuberculosis. As he already said, there is it presents with a myriad of features like granulomatous anterior uveitis, solitary or multiple choroidal nodules, neuroretinitis, subretinal abscess, focal and multifocal choroiditis. And the diagnosis depends upon various things like the migration from an endemic area, the history of contact, the suggestive ocular findings, along with a positive TST and a positive response to a ATT. So we need to basically rule out masquerades and infectious uveitis before we treat these patients with steroids, immunosuppressives, and more recently in refractory cases, they will need biologics also. Thank you.
Thank you, Dr. Vinita, for the elegant talk. and highlighting various salient points of panuveitis.